Welcome everybody to our session on workforce challenges. This is one of my favorite topics these days because what we're noticing is that we have to reimagine our healthcare workforce in the same way that so many other things are being reimagined. And we used to have this like planning sessions around crisis, and then we used to have planning sessions around transformation. And those were usually kept separate, right? So either you're planning for a crisis or you're planning for a transformation. Well, what we're seeing today is those are not distinct and disjoint topics anymore. The crisis is requiring the transformation, and without a transformation, you can't do the crisis management. And so this discussion is going to be around the fact that our clinicians, of course, within the health systems, the frontline workers who are more heroic than ever. They've always been heroic in many cases, but these days, everywhere you look, you see an enormous amount of heroism showing itself on a regular and routine basis. Now, even though that heroism is showing, there are tons and tons of challenges that we're going to cover today. And we couldn't have picked a better moderator than Amy Waldron. Amy works for a small company known as Google. You may have heard about them. They help hospitals and health systems with these transformation goals. And if any company has helped transform remote management, remote work in the last 15, 20 years. With that, I'd love to hand it over to Amy, and Amy's going to introduce the rest of the panel.
Oh, thanks, Shahid. I appreciate it. And welcome, everyone. I'm Amy Waldron. I'm the Director of Strategy at Google Cloud, focused on healthcare and life sciences. And like many of you, we are focused on supporting the communities through this COVID-19 pandemic. Most of it focused on data and technology, really kind of looking at what we can do from high-performance computing to providing access to information about the disease, as well as analytics. And last but not least, looking at how we can help our frontline workers with enabling virtual care. So with that said, COVID-19 has put significant stress on our health system and our healthcare workers. The session is really going to focus on some of those challenges and how organizations are pivoting to provide the needed support for our clinicians and others providing that care. In addition, we hope to have some time to address some of the opportunities for change as well as advancement. So like Shahid said, I'm privileged to have two amazing speakers with me, both influential voices in the healthcare industry. The first one is Dr. Esther Chu. Esther is an active contributor and thought leader around health disparities, as well as has been a very, very frequent expert on MSNBC and CNN discussing what it's like on the front line for workers dealing with COVID-19. The other presenter is Joe Mascola. Joe is the Chief People Officer at Northwell Health, a very significant and diverse system based in New York. In addition to tackling many challenges with regards to gun violence, immigration, and health disparities, clearly we have watched a lot of it on TV as they have been one of the first centers of addressing the COVID-19 pandemic. So with that said, let's get started with some of the questions so we can hear insight from both of you. Earlier, Dr. Dean spoke about healthcare workers and them having to navigate tough calls and ethical quagmires while maintaining the high standards. This isn't new, but clearly the sheer volume with COVID-19 has taken its toll. Can you share what you're seeing in this area with regards to COVID-19, and how are you helping the people in your organization navigate these situations?
Yeah, I can start. I mean, you're absolutely right. There is a certain scale of crisis that COVID presents to us, and there are just many layers of newness that we've had to contend with. So yes, we have disaster protocols in place. Yes, we are actually built, all health systems are built for kind of discrete disasters, you know, single mass casualty events, regional natural disasters, something like this that's a global pandemic. Where in certain places, starting with New York, we've had to deal with tremendous patient volumes, high acuity of disease, and unknown disease, actually, that we had to learn about every day, so that you'd walk in my hospital. I'm in Portland, Oregon. We've had a very different experience so far, but still, in my hospital, you would walk in and start your shift, and by the end of the shift, the protocols had changed. I mean, we've never had to practice like this. And even hospitals that were not we're not hit like New York hospitals had to prepare to be hit like that sometimes. So it really was transforming our physical spaces, our clinical protocols, our understanding of the disease, our management of patients who were not COVID patients, and then supporting a workforce that was really, in many places did not have capacity for the type of volume that we've seen. So I think, in terms of how we've been supporting people, I mean, I do think, there is something about a crisis like this where everybody steps up and starts operating at the top of their potential. And so I think, we built off existing protocols. We started with our existing disaster response, and we scaled up from there. And then I think everybody had to give something. So I'm based in the emergency department, and we had to figure out quickly how we could transform our space, thinking of our space as a place not just contained within the walls of the hospital, but even beginning outside on the hospital grounds or surrounding areas, and then figure out ways that people could enter our hospitals safely, be triaged quickly, and be exposed in as little as possible, so that we could have disease containment, even as we scaled up our care capacity.
Thanks, Dr. Cho. And just like Esther just described, I think one of the things that made COVID so unique is that it is so prolonged. Normally a hurricane, you prepare, the situation hits you, and then you do your hot wash or your recovery to understand how you could have improved, and that's where that sort of transformation from that crisis tends to occur, and it tends to be somewhat self-limited. I think here at Northwell, and just to provide a little bit of context, we typically run about a little bit north of 4,000 beds, staffed beds. At our surge, we went up to 5,000 beds, 80% of which had COVID-positive patients in them. Of that 80%, north of 30% were in our ICU. So the amount of capacity we had to create in a very, very short time period, and as Esther said, of a disease that we really didn't know anything about. We were all flying blind, and crisis leading to transformation. It was occurring on all levels, from a scientific standpoint to a caring standpoint. How do you care and care for the whole family and communicate to a family when you discontinued and limited visiting hours? And so that's a process that we clearly came to understand is so critical, not only the family but the team members as well, the nursing, the clinical staff. That's human connection. That's why we entered this space. That's why we entered this industry. And in many ways, they were doing it over virtual or over the phone, and it just didn't have the same ability to connect with the patient in the bed, who is, by the way, oftentimes intubated, sedated, and paralyzed. And so it created this, when you talk about the humanity or the humanism in healthcare, it really put that to a strong challenge. So how do you preserve the resiliency, as we've really come to talk very frequently about it here at Northwell? If you can imagine a bell curve, at the beginning part, we really frame this as instilling confidence. You have the right equipment, you have the right protective equipment. We're going to do everything we can to keep you safe, your family safe, and the community safe. You then recognize the heroism, and that is where truly remarkable the outpouring of love, and I use that word by design, of love from the communities that live around the hospitals. They see what the hospital workers are doing, running into them each day in the context of uncertainty. Then you have to manage the fear. There is going to be fear. The long-term sequelae of this disease still unknown. The virulence and so much still unknown there. So much that we came to learn about its impact in different communities, hitting some harder than others. We'll talk more about that, I'm sure, as time goes on. And then we have to reward the bravery and the commitment, make sure you acknowledge it, and then clearly give time. I cannot underscore this enough, to the healing and the recovery, that respite, that ability to allow the mind, the body, and the soul to just sort of recharge, regenerate, and get back to normal. Some concrete ways of how we did that. When you walk into our facilities, we have team member entrances. We put, in some cases, tents outside of each of those entrances, and we call them tranquility tents. In there, we had a combination of just fun and healthy foods, snack bars, different drinks, healthy drinks, vitamin drinks, things of this sort. We had our chaplaincy in there, who just did an absolutely extraordinary job of rising to the occasion, being there in person. We had other EAP services, employee assistance services, and just an availability of space, tranquil space for people to have a time to just unwind. Another very practical example, we have these things called team lavenders. Team lavender, anyone can call a team lavender. Doesn't matter whether you're the environmental worker in the emergency department, or whether you're the nurse or the doctor or the respiratory therapist. But if you just need a timeout, hey, we just had a situation that's hard for me to wrap my mind around. We got to call the team together. What happens in those sessions? Sometimes nothing but peace and quiet amidst otherwise chaos. Sometimes it's people talking and talking about how they felt. Sometimes it's music. At times, pre-COVID, we would bring in a pet therapy and have a dog there or something like that. Obviously, we didn't expose them to this situation, but this is something that if it didn't exist at the time of COVID, we made sure we broadened it throughout our entire and transferred those concepts throughout every site, so that our team members had a way to really just release and be together with a common mission and common cause. In addition, we did establish a 24/7 peer calls hotline. That's not only inbound, but outbound as well, where we would, and this came from some of our physician community, where we just need to check in on certain people. We all deal with these things in different ways, and so just the notion of saying, hey, Joe, how are you? And just allow the silence to just sort of sit for a moment and then see how the person responds and allow them to express themselves in those settings. I think we certainly had, In addition, one thing I will sort of end the thought on is for any of those team members who were in direct support of the front line or on the front line, we provided a $2,500 recognition bonus for during that period of surge. In addition, we gave them a week's time off. So we wound up spending $140 million, and you say, oh my goodness, healthcare organizations spent that much money amidst COVID? Yes, because we felt it was important to acknowledge. And we did it as a universal amount. Didn't matter what your role was. Everyone got the same amount, from doctor to environmental worker to home health aide, to acknowledge them for their efforts and their heroism. So that was our way of sort of really acknowledging and rewarding the bravery.
Excellent, thank you. Thank you both. I do think that some of the very positive things that have come out of this, for better or worse, pandemic is, Esther, you mentioned it, just bringing out the best in people, and really the natural teaming and people coming together in a time of crisis is just, I think, been remarkable, and said a lot about why so many people get into healthcare, but also why so many people really come together and how they can come together as a community. So Joe, you talked about so many wonderful responses that just really, they help support people physically and emotionally. As you think about, the coronavirus, for better or worse, it seems like it's going to be, hanging on there a little bit longer, and who knows what's next. Can you just share a little bit with regards to resiliency? It's clear that you guys have pivoted quickly and, have created this gigantic playbook that has given you lots of levers to address different types of needs out there. What do you think about, what will continue as we try to, develop resilient cultures, and, what do you think will kind of stay in place, or what would you like to see stay in place?
Yeah, I think the first part that really, when we talk about making sure we instill confidence, acknowledge what you know and what you don't know, and be open to feedback. Early on, it was clear, we've got to start putting surgical masks on everyone to start to protect. We don't know exactly how this is being transmitted. And then you get, a couple weeks go on, you say, well, we need N95 masks. And we need them in our ICUs, we need them in our EDs, et cetera. And then you have a couple team members who come to you and say, hey, how come the nurses and the doctors, but here I am, the unit secretary, the unit clerk, I don't get an N95? And you're like, no, you're right. And then you walk through the physical unit and you're like, they have to have one, unequivocally. The point being, if you're going to start on the resiliency path and you're going to instill confidence, make sure you listen to the feedback. The second part is, as we all now understand, this is a pretty bad disease and virus. And so acknowledging the grief. We had a day of remembrance. We did lose 20 Northwell team members. And so we held a day of remembrance, both in person and virtual, socially distant. But we invited their family members in for us to grieve with them and to make them part of our family, and if they would have us be part of theirs. In addition, we made sure we did everything possible to support those families, because not only did it sort of lift up the family, but it lifted up the site where those team members work, those hospitals, to see that the organization put them first, their sacrifice. And so it didn't matter whether they got it from the community or whether they got it from at work. To us, it didn't matter. This was a healthcare worker.
Excellent, thank you. Esther, I'd like to hear if you have anything else to add on this topic, but I also would love to pivot a little bit with you on some of the different writings that are out there that you have created, specifically creating a healthcare culture of excellence. So can you share with us what that means, and better yet, how has COVID-19 impacted your vision and thoughts about this concept?
Yeah, when I talk about a healthcare culture of excellence, what I'm referring to is building a culture in which equity is treated like other goals that we have and aspirations that we have for our healthcare workforces. So, you'll often hear that an organization is a stroke center of excellence, or it's a heart care center of excellence, and we have specific expectations and parameters and actually metrics and national standards that we meet. When we talk about having a culture in which people feel equity, they feel valued, they feel respected, everybody, and they feel trust in their leadership. Those are not things that we put specific metrics for. We don't have well-articulated targets. We tend to have platitudes and very vague goals and mission statements. And I think that's probably why, particularly for women and for minorities, for minoritized physicians and other healthcare workers, we haven't actually made a lot of palpable progress in representation or in how accepted and safe people feel in these organizations over the past 30 or 40 years. It's been pretty static. And so I think, I'm primarily a researcher in addition to being a practicing emergency medicine physician, and it always frustrates me that when we go to topics like inclusion, representation, and equity, we are, as people of science, we are very non-scientific about these things. We apply very little rigor. And I think those dynamics played out so acutely in COVID. I just watched them nationally. I've been on a lot of panels and I've been asked to serve on a lot of committees and task forces, both locally and on a national level. And it is very obvious who we turn to in times of crisis, who we consider the natural leaders are, how our instincts, our habits are not to build inclusive and representative teams. And it's sometimes been very optically uncomfortable because you see leadership that is pretty homogeneous, making decisions about kind of risk tolerance for large staffs that are much more diverse, and there's been a couple of really notable examples in the media where a healthcare organization will put out something where they're kind of highlighting their COVID response, and you see it's the march of the white male administrators, and then they show the people on the ground face-to-face with patients, and those are all the people of color. And I know these things are, that people are very aware of them, that organizations, particularly with the national conversations around race and health and health disparities, These are things that organizations are acutely aware of, are determined to be better about. I think all of us right now are sitting with our discomfort and trying to figure out, how do we build a new health system in which our workforce, including its highest leadership, can look a lot more like the communities that we serve, so that we have a much better chance at tackling these really grave health disparities. And I know Northwell actually, there was a race to get out the first paper about health disparities in COVID, and Northwell won. And actually, when that paper, was it in the New England Journal? When that paper came out, I got all these messages from other health services researchers who said, damn it, Northwell got to it first. I think when you're really like embedded in your community and you care about it, you're interested in the data, you push these issues out quickly so that your healthcare organization is really committed to making a difference and providing equitable care to your entire community. But I really think we're coming to an understanding that part of really living up to that mission is having within your workforce the right representation and power and values.
One thing is clear, this topic is, frontline news. So it's great. This is not a new issue. How do either one of you feel that we actually can make substantial traction, or what have you seen that's working? What do you recommend? How do we actually not just acknowledge it, but make strides to accomplishing something meaningful here?
Sure, I'll jump in and I'll just be a bit responsive to some investors' comments. You have to talk about it, and you have to acknowledge it, and you have to be transparent. The article that Esther just mentioned, that came out, and it was a little uncomfortable within the organization. One, great, it got out, we published. Two, it's like you're met a little bit with, hey, did you see this? This is out there. And it's like, yeah, that's right, it's out there, and we got a problem, we need to fix it. So the first I would say is you have to talk about it, you have to be transparent about it, and you have to acknowledge it. That's the hardest part of the journey in a way, but it's the most, and it's thereby the most critical. But it's from there that the actual transformation and if I may, the most enjoyable work comes, because you want to talk about making a difference. That's truly where it happens. It was from that Northwell, and really under our CEO's leadership, decided, okay, testing, we're going to get out into the exact communities that need the testing the most. So we have tested in some of the most populations in all of New York City, 45,000 community members for free to understand their serology, their antibody sort of positivity or not. And the more we can do that as leaders, is the more we'll really solve some of these problems. And they've existed for a long time. We were talking maybe to tee up Esther right before this call started, or this session started, and it was about health inequities amongst gender, amongst women, particularly within cardiovascular disease, that has existed for a long time. But how far have we gotten there? And yet, there's still room for improvement. But crisis creates transformation, and the major emphasis from what happens in those things is movement, and the movement from one place to another, and the speed at which we do it. And I think that's where COVID has been particularly unique in that sense.
Yeah, I totally agree with all of that. And I think there is a lot of reluctance to even admit there's a problem. And I think the silver lining of this year, just to put it as positive a spin on it as possible, is that we cannot ignore it anymore. And I think COVID is making us realize that not only do we have to deal with these really grave health inequities in the moment, sort of pivot and do better as we go in terms of every single response. But we actually should never go back to normal, because it was, like you said, Amy, everything was there. The structural racism was there. The, the gendered racism was there well before. It's just that COVID has this really amazing quality of bringing everything to the surface and making it really raw. So I agree, we need to continue these conversations, use very specific language in calling it out, because it's not just about being better or having more positive cultures. It's actually about addressing structural racism in our health systems. We need to actually have very few parameters on what we consider to be healthcare, because, part of the reason that we are in this pickle is because, because there's a housing crisis that breaks down by race. There's a wealth gap. There is an access to healthcare gap. There's an access to healthy environments and foods gap. All these things are kind of built into our societal structures, and we cannot fix it by the time people come to the hospital. And then, of course, there are many layers of inequities that happen from the minute you walk in the door. I mean, if you're Black and you develop COVID, you are half as likely to have been tested before you hit the hospital. In other words, you have to be much more sick, even hospitalized or needing the intensive care unit before you get a COVID test. That's addressable once you get here. But what happened out there? What were the access issues? So I think, addressing it, attaching specific targets, being very data-driven like we are about any other problem, a huge investment, workforce transformation, leadership transformation, and really aspirational goals. I don't even use the word diversity anymore, because I think that's such an upstream goal. Of course, we need diversity, but how about we aim for equity, inclusion, and a place where everybody feels valued and can advance. That will create diversity as a byproduct. We don't need to aim for diversity as a check mark. So a lot of work to be done.
You're absolutely right. It's ironic how, I would have to say, one of the greatest attributes of this country is all the innovation that results from the diversity that we have within our country. And yet, there are a lot of very, very serious inequities that are uncomfortable to deal with. And I applaud both of you and many others for being willing to remain in this uncomfortable space so that we don't go back to normal, that we actually take this opportunity and we take the I would say, press and the movement around this and actually do something with it. So thank you both. We're kind of getting towards the end, so I was hoping to end on a positive note here. This is a very serious, daunting topic, and I do think it's brought out a lot of good and hopefully has opened the door for some change. So I would love for you guys just to share in closing what is something positive that you have seen as a result of this pandemic, or what is something that you think is going to emerge in the future that is going to put us in a better place?
I think healthcare providers have not always seen themselves as science communicators, and people who really bear the responsibility for for informing the public, for explaining the science, and for really kind of guiding the public health conversations. And I think, I've seen hundreds, maybe thousands of healthcare workers of all roles really step up and grow into that role. I mean, how many of us were comfortable on TV before that? I will tell you, we scrambled and did a little ad hoc media training. Joe's smiling. I feel like maybe you've also felt this. The first time I was on TV, I spent, all this time practicing what I was going to say, and now really it's more of an everyday thing, and you're just going to wing it, and that's fine, but you have certain points you just need the public to hear. I think we're all much more comfortable in that role, not just comfortable, but we feel like in light of all the misinformation out there, it is truly 100% in our wheelhouse and our obligation, and as vital as our clinical roles these days. And it's been so wonderful to watch people rise into these roles, and I think it really is a turning point for how we define healthcare roles and their importance as spokespeople, as elected officials, as people driving policy and decision. I think this was a hard lesson, but I think we probably will never step out of these roles again.
So well said. I think, Esther, just as you said, it's like, hey, can you be on this interview in like 5 minutes? And you're like, oh boy, I don't know if I'm ready for that. But yeah, it's definitely lessons learned. You know, two things in particular that I'm grateful for COVID for. One, and maybe a response you might expect as the Chief People Officer for our organization, but I am so much has been said in the public discourse around healthcare pre-COVID. You know, it costs too much, it takes too long to get in, et cetera. The science, et cetera. You know, I am so proud that the healthcare workers got all of the attention and recognition that I have long believed they so deserve. The heroism that they do. It is one of the, as I say to our team members all the time, it is the only industry that you can deal with life to death and everything in between. And it is some of the most sacred moments of life, and we get to be there for it. And to me, that's pretty special. And the fact that the community began to recognize that, and not necessarily the only conversation around cost and access, and that was sort of a special moment. And it continues. I think we really feel that certainly in the New York market, and we hope we continue to rise to that occasion. The second thing is, yeah, I think we've just moved faster. There are certain things that we were able to get done here, and I'll even say it just more from an administrative standpoint. It's like, wow, that would have taken us years, but we did it in days, weeks, months. And then the level of collegiality in terms of movement, the level of collegiality amongst the nation, because we're all struggling to figure out and solve the same problem. So it's said differently, the level of innovation occurring now, you know, within our catchment areas, outside of our catchment areas, I think we will all move much faster as an industry as a result. And so,
well, I, on behalf of so many people, want to just let you know how grateful that all of us are with regards to the two of you and many others in your organizations and other organizations being such advocates for critical social issues, as well as just, you know, being there on the ground supporting the front line who are, you know, treating so many people who are in need. Also, thank you for sharing your perspectives and insight. I'd like to take a step back and open this up to questions coming from, you know, the other participants.